Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Stoke Therapeutics, Inc.
Hello, and welcome to this program titled Rapid Reports in Dravet Syndrome, Synthesizing Pipeline Developments. I'm Scott Perry, the head of neurosciences at the Jane and John Justin Institute for Mind Health at Cook Children's Medical Center in Fort Worth, Texas. I'm joined today by Dr. John Schreiber, who's the Associate Chief of Neurophysiology at Children's National Hospital in Washington, D.C. In this short, rapid fire program, John and I are going to discuss therapies under investigation for Dravet syndrome. We'll each ask each other questions, and then we'll have 90 seconds to answer each question. Before we get to the investigational therapies, let's review what's currently available for Dravet syndrome. Right now, we have 3 FDA-approved medications which have indications specific to Dravet syndrome: stiripentol, fenfluramine, and pharma-grade cannabidiol. Now, in 2022, there was an international consensus for the treatment of Dravet syndrome, and as part of that consensus statement, valproate was listed as first-line therapy, whereas fenfluramine, stiripentol, and clobazam were considered second-line therapy, and finally, third-line therapy was pharma-grade cannabidiol. So, John, as we start to think about these treatments we have for Dravet syndrome, what would you say are the limitations of these therapies, and why do we even need to consider new therapies?
Thanks for that question. There are several limitations of current therapies. First, the existing therapies you mentioned, while they are specific to Dravet syndrome, they still focus primarily on seizures. Often the goal is seizure reduction, but not necessarily seizure freedom. In some instances, we can achieve seizure freedom, but that is not entirely typical. These therapies don't address non-seizure symptoms. So we know that there are other symptoms besides seizures that are really important for families, for patients, and quality of life. And these include things like developmental slowing, intellectual disability, attention problems, autism spectrum features, motor and gait problems, sleep issues, and an increased SUDEP risk. And oftentimes, more medications can just contribute to worsening quality of life because these medications can have side effects and there can be drug interactions. We know that many of them can cause somnolence, can cause fatigue. There can be potential risk for cardiovascular effects with medications like fenfluramine. And then there's issues of access to these medications. These are therapies that have a cost, and they're also labeled as adjunctive therapy for the treatment of seizures associated with Dravet syndrome. So, Scott, when we talk about investigational therapies, we talk about those under investigation for seizure control and potentially disease modifying therapies. Let's start with the ones that are under investigation for seizure control. Tell me about bexicaserin.
Yeah, so bexicaserin is a medication whose mechanism of action is a super agonist that is highly selective for the 5-HT2C receptor. So this is a serotonin receptor expressed in GABAergic and glutamatergic neurons, which contributes to the imbalance of inhibitory and excitatory modulation and then ultimately epileptogenesis. I think the way you'd think about this medication is fenfluramine, for example, acts on these receptors too. And what's different about this drug is because it's specific to the HT2C and not the 2A and 2B receptors. We have a drug that won't require the echocardiograms that are required with fenfluramine. So that's one of the big differentiating factors. Now, it's been studied so far in a phase 1b/2a study called the Pacific study. This was really a basket study, so there were a lot of different patients with different kinds of developmental and epileptic encephalopathies included. But among the 52 patients included, four of them had Dravet syndrome. The drug is administered 3 times a day. There was a 15-day titration and then a 60-day maintenance period. And among those who had Dravet syndrome, 72% reduction in countable motor seizures was seen in that group. The drug was overall well tolerated, so most of the adverse events were considered mild to moderate, and there were typical kinds of things we see with drugs for seizures, things like somnolence, decreased appetite, and constipation. This drug is currently continuing in a phase 3 placebo controlled study investigating it in children and adults with Dravet syndrome. And that study is currently recruiting. So we hope to have even more data about this drug in the future. Now, another drug that's out there under investigation right now is clemizole. So, John, tell us what you know about that one.
Yeah, thank you. So, clemizole again is a drug that's being explored for seizure control. It is a first generation H1 histamine receptor antagonist. It was actually identified by screening a drug library in zebrafish, SCN mutants, looking at multiple different compounds, and clemizole stood out as a potential for targeting seizures. It has high binding affinity also for these postsynaptic serotonin receptor subunits, the HTR2A and 2B. And it's currently undergoing a phase 3 clinical trial in participants with Dravet syndrome, known as the Argus study. So, Scott, the second category of investigational therapies are disease modifying therapies. What are clinicians and families looking for when they talk about disease modifying therapies for Dravet syndrome?
Yeah, so when we talk about disease modifying therapies, what we're talking about is a therapy that is truly going to change the course of the disease for the person that has it. So for Dravet syndrome, we are going to change the natural history, the course of this disease, more than just the seizures. We're going to target both the seizures and hopefully also multiple non seizure symptoms. And the way we do this is that these therapies are truly targeting the underlying cause of Dravet syndrome. So, specifically, that SCN1A abnormality that's present, that's what the drugs or the treatments want to target. And this is what is really considered precision medicine because we're getting to the underlying true genetic etiology. And of course, when we talk about disease modification, I mentioned, these treatments as it relates to Dravet syndrome are centered and focused around the SCN1A gene. John, explain to us how SCN1A is associated with Dravet syndrome.
So, SCN1A is the most common cause of Dravet syndrome. It's identified increasingly as our genetic testing has improved over the years in patients with Dravet syndrome. There are a couple other genes that have been identified, but by far, SCN1A loss of function variants, which lead to haploinsufficiency, are the cause of Dravet. The SCN1A gene encodes the alpha subunit of the voltage gated sodium channel NAV1.1, highly expressed in the brain, also expressed in tissues like the heart. The variants that are responsible for Dravet syndrome can be missense, or they can be protein truncating variants, or sometimes due to abnormal splicing. And it results in seizures because it decreases activity in these voltage gated sodium channels that are expressed in these GABAergic inhibitory interneurons. So you've got reduced excitability of these inhibitory interneurons that lead to those symptoms like seizures. So the investigational therapies we're discussing now all target that SCN1A gene. They get at that genetic cause. Scott, tell us about the first one, ETX101.
So, ETX 101 is an adeno associated viral vector therapy. And so, I think in simplest terms, to describe what's happening here is they've taken a virus, and just like you can get a virus that gives you a lung infection or a GI infection, you can train viruses to infect what you want. So, in this case, This virus contains a GABAergic cell selective regulatory element, which allows it to bind to the GABAergic inhibitory neurons that you just mentioned that are involved in Dravet syndrome. So when this virus binds to those inhibitory neurons, it essentially infects it with what is a transcription factor that binds to the SCN1A DNA and then promotes transcription and subsequent translation of SCN1A to create more of the end product, which is the sodium channel protein. Now, the early mouse studies for this using a Dravet syndrome model showed that the therapy provided improved long term survival as well as a reduction in seizure frequency. In the non human primate studies, adverse effects were relatively mild. There was some minimal to mild elevations of liver transaminases, which has been seen with other AEV therapies, resolving without intervention. And phase 1 and 2A studies have been underway in the US and the United Kingdom as well as Australia. Now, there has been some preliminary data released from these early studies. And among those patients with Dravet syndrome that got the highest doses of this viral vector through 32 weeks, there was a 78% reduction in the countable major motor seizure frequency. And there's also been some clinically meaningful improvements in neurodevelopmental outcomes as measured by the Vineland-3 or the Bailey-4, which are common measures we use to look at these non-seizure developmental outcomes. And overall, from an adverse effect perspective, it has been very well tolerated. Again, as expected, there's been some mild elevations of the transaminases, but these have been asymptomatic. They've been able to treat them with steroids. So, a favorable profile thus far from these early results. There is a randomized double-blind sham-controlled trial that is starting now, actually. So we'll be enrolling in the very, very near future. John, another disease-modifying therapy out there is the antisense oligonucleotide therapy, zorevunersen. So tell us a little bit about that.
So zorevunersen is another type of gene therapy. This is an antisense oligonucleotide. It promotes exclusion of a poison exon that leads to non-productive mRNA transcripts and therefore increases the level of productive SCN1A transcripts that turn into that voltage gated sodium channel, that NAV 1.1 protein. We have different types of poison exons like this in different genes, and this is just a way of also increasing that gene expression. It increases both the wild type and the mutant allele, but the idea is that you're increasing that wild type allele and you get more functional NAV 1.1 protein. So this is a phase 1/2A open label study that is completed, included 81 patients aged 2 to 18 years with Dravet syndrome, and 85% were taking 3 or more anti-seizure medications, a pretty refractory group or pharmacoresistant group. Patients received ascending doses starting at 10 milligrams and increasing all the way to 70 milligrams that were administered intrathecally over time. Again, they looked at efficacy at that highest dose, that multiple doses of 70 milligrams, and they found at least a 50% reduction in convulsive seizure frequency in 80% of patients at 3 months and 77.8% of patients at 6 months. Also, looking again at these non seizure outcomes, they saw improvements in adaptive behavior, the overall clinical status, and quality of life in the first 9 months. And they found that in terms of safety, that the doses were well tolerated. The most common adverse events that were reported were elevations in CSF protein, which was asymptomatic, and also symptoms like vomiting. Patients after receiving those loading doses receive maintenance doses of 45 milligrams now every 4 months in this open label extension study, and they found similar durable reductions in convulsive seizure frequency at 12 and 36 months. Additionally, clinically meaningful improvements in cognition, behavior, and functioning at 12 and 36 months administered through the Vineland and some other scales. And doses continue to be well tolerated, again, with similar adverse events reported in the open label extension study. It also has gone on to a phase 3 clinical trial. So, this is a randomized sham controlled trial in patients aged 2 to 18 years with SCN1A positive Dravet syndrome. The primary outcome measure is the change in motor seizure frequency, and secondary outcomes examined are change in cognitive and behavioral symptoms as measured by the Vineland Adaptive Behavioral Skills. So we've talked about investigational therapies for seizure control and potentially disease-modifying therapies. Scott, what do you see as potential benefits of these relative to what we already have?
Well, I think the easiest and most obvious benefit is the disease modifying therapies have the potential to do more than just impact seizure control. So now you not only hopefully get a reduction of seizures, but hopefully improvements in development, motor function, behavior, sleep, etc. Who knows what we're going to see as the phase 3 goes on. I think some other potential benefits when I think of these newer disease modifying therapies is, for example, ETX 101 is a one time therapy. So if that one time therapy provides a lot of benefit, that's going to be considerably different than what we have now. I think we should overstate that one time therapy is going to solve all the problems. It's not. I think these patients are still, of course, going to need some medications, but I think we have the potential, hopefully, to limit that and impact some of these non-seizure outcomes. So I think that's really as exciting change in the field of this condition. What do you think, John?
Yeah, I agree entirely. I think there are opportunities for these medications to address many of these non-seizure symptoms. They may offer additional benefits in seizure control as well in patients who have been on everything else, have tried everything. I think the other hope is that if you can design therapies that are specifically addressing the underlying cause, they'll be more selective in terms of reduction in adverse events that you can see. You're more selective for that actual SCM1A gene in this case. And hopefully, you'll see less off target effects, less of those adverse events, which can be really important for quality of life.
Well, yeah, that's great, John. I appreciate that. And thanks for a great discussion. And of course, thank you for participating in this activity. Please continue on to answer the questions that follow, as well as completing the evaluation.